Hello, class. So we are all online, I guess, now. So we're going to be recording lectures and putting them up on Moodle. And um, I hope you are all well and your families are all well and you're taking care of yourselves and you're using PPE appropriately at your workplace, um, and that they have enough supplies for you all to be safe at work, those of you that are working in the medical field. All right, let's talk about the cardiovascular system and adult perfusion. Let me see here. So the student learning objectives for this video, I'm going to just review the anatomy and physiology from your anatomy and physiology class and from your lecture last semester, and then we're going to talk about age-related changes in the cardiovascular system. And then I'll be making a second and third and possibly a fourth video to cover this. Okay. So let's start with the structures. Let's start with all the components of the cardiovascular system. So first, we have the four chambers of the heart, hollow chambers, and they're separated by septum between the two atria and the right and left atria and the right and left ventricles. So the heart's about the size of your fist. It lies mid-sternal. And it's composed of three layers: the endocardium, the inside, the inner layer, the myocardium, which is the muscle, and the epicardium, the outside layer, the outer layer. And the heart is surrounded by a fibroserous sac called the pericardium, which has two membranes, just like the lungs. The inner one is the visceral membrane, and the outer one is the parietal membrane, and there's some fluid, a small amount of fluid between those two membranes that kind of protect the heart, lubricate. And let's see, I think that's about, the thickness of the myocardium. So the walls of the myocardium are more thin around the atrium, a little thicker around the ventricles, but the left ventricle, especially because it does a lot of work, is 2 or 3 times thicker than the right ventricle. The blood flow. So we're blood flow coming up into the right heart from the body, using the inferior and superior vena cava, going into the right atrium, through the tricuspid valve into the right ventricle, through the pulmonic valve into the pulmonary arteries, and then to the pulmonary capillary system being oxygenated, which we talked about last lecture, and then returning back to the left side of the heart. In this diagram, this is oxygenated blood now, so it's red, going back into the left side of the heart, entering the left atrium through the mitral valve into the left ventricle and out through the aortic valve into the aorta and out into the body systems. So that is the blood flow. Now, the heart valves. So the 4 valves, which you are familiar with because when you first started here, we taught you where to put your stethoscope so that you could hear those valves, and you have been listening to them now, hopefully, in your clinical sites. And what you're hearing is those valves close neatly. Yeah. So let's see what I need to say about this. It just the valves prevent regurgitation back into the chamber. The coronary arteries, which we need to talk about a little bit because we're going to be talking about coronary artery disease. So once the blood leaves the left ventricle into the aorta, some of it goes into the coronary arteries, which are arteries around the outside of the heart that provide the heart with pretty much a constant, freshly oxygenated supply of blood, which the heart requires. So the right coronary artery is feeding the right atrium, the right ventricle, a portion of the posterior wall of the left ventricle. And the left coronary artery is feeding the left atrium, the left ventricle, and the interventricular septum and a portion of the right ventricle. So these are important to know if you're studying, if some of those arteries become occluded, you'll know which part of the heart could possibly be affected by that. Okay, so the heart has its own unique conduction electrical system, which starts with the SA node, which is in the right atrium, the wall of the right atrium. It starts there. It follows these electrical pathways into the AV node, arterial ventricle node. I'm sorry, not arterial, atria ventricular node, and then follow pathways into the ventricles electrically. Okay, so we have EKGs. I'm sure you've all seen some of those now. From the outside of the body using electrodes, we can kind of track that electrical activity of the heart, and we'll be talking more about that. Okay, I think that's about all we need to talk about when we're talking about the cardiovascular systems. So these are some terms that I just wanted to remind you of. I'm sure you've learned them. Systole is when the heart's contracted. Diastole is when the heart's relaxed. So we learned about that with blood pressure, when you were studying blood pressure. The stroke volume is the amount of blood pumped out of the heart with each beat, and it's measured in milliliters. And the cardiac output is the amount of blood pumped out with each minute. And that's also measured in milliliters. The preload is the amount of blood in the ventricles at the end of the dystole, so at the end of the relaxation period of the heart cycle. And contractility is referring to the strength of the contraction of the heart. Afterload is referring to the amount of peripheral resistance which the left ventricle, has to work against when it's pumping blood out into the system. Okay, patient is receiving a drug that decreases afterload. To evaluate the patient's response to this drug, what is most important for the nurse to assess? The heart rate, the lung sounds, the blood pressure, or the jugular vein, venous distension. So if we're talking about afterload, that's the amount of resistance that the left ventricle has to deal with when it's pumping blood out. And the way that we measure that is with blood pressure. So let's talk about gerontological concerns. So the risk of heart disease increases with age, and cardiovascular disease is the leading cause of death for adults over the age of 65. Many times it's hard to unravel whether cardiovascular disease is caused by age, by disease process, by lifestyle behaviors. So there's a lot of considerations. So with age, we have the heart becomes less elastic. A lot of the myocardium part of the heart, the elastic, more healthy tissue is replaced with scar tissue and collagen, and this tissue is not nearly as contractible. So that makes the heart muscle weaker. One of the other major changes is the response to stress. So normally you would have an increase of heart rate when there's physical or emotional stress. But with elderly, the ability to increase and decrease the heart rate changes. It's not nearly as sensitive. So this you will see with exercise, especially, let's see. The maximum heart rate during exercise will decrease. And we're just, as we age, not as able to respond cardiology wise to stress. Okay. The heart valves become thicker and stiffer, which we would refer to as stenosis. So this makes them not able to snap shut as efficiently. So you can have some cardiac regurgitation. And that makes for turbulent blood flow, which can complicate. And that's what you're hearing when you hear a murmur, when you listen to the heart. The number of pacemaker cells in the SA note. So this is referring to the conduction of the heart, the electrical activity of the heart. That decreases by quite a bit with age. And that makes people who are older more at risk for dysrhythmias and EKG changes. Okay, so blood vessels themselves, the arterial and venous blood vessels become thick and less able to expand and to dilate and constrict. Become more sensitive to ADH. So we know what ADH does now because you've had your fluid electrolyte lecture. So if you're more sensitive, reacting more to the ADH, you can imagine that's going to cause you to hold on to more water and salt, which can present fluid problems. There are changes in the systolic blood pressure. It tends to rise, whereas the diastolic blood pressure will either decrease or not change at all. So your total pulse pressure will increase with age. The valves in the venous system, that push the blood back up to the heart, especially in the lower extremities, they become less efficient. So elderly patients may have venous flow problems, venous stasis, edema. Orthostatic hypotension, our bodies are not become less able to deal with position changes and adapt quicker. So you may see changes with elderly having symptoms of orthostatic hypotension. And then also postprandial hypotension, so lower blood pressures after eating. So these are times, position changes and after eating are times when a patient may experience orthostatic hypotension and times when we would need to be worried about falls. Okay, so let's see here. So that's all I'm going to record for this lecture, and I will be recording a second lecture for coronary artery disease. Okay.